levels of vitamin D do seem to be much more prone to type 1 diabetes. So I guess we should start letting our children kick around the garden where they come into contact with soil, and I guess we should start giving them extra vitamin D. But what we mustn't do in the first few months, probably 6 months, a year of life anyway, is give them cow's milk. Bovine serum albumin in cow's milk is bad for them. Again, it can trigger off these autoimmune reactions. And we shouldn't be giving them cured or smoked meats, and we shouldn't be giving children coffee either. All these things have been they're not proved to cause type 1 diabetes, but they are associations and things best to be avoided. So how are we going to recognize that someone might be developing type 1 diabetes mellitus? Well, there is a classic triad of presentation, and that classic triad is polyurea, excessive volumes of urine, thirst, and weight loss. This is the classic triad that should alert us to the possibility that diabetes mellitus is presenting itself. And we've said that the antibodies are going to take quite a long time to destroy the beta cell mass, and when 70 to 90% are destroyed, clinical features are going to occur. And even though it can take a long time for the immune system to destroy the beta cell mass, the presentation can be relatively acute. So the patient might present with just a few days' symptoms. The sooner the better, obviously, but it can be a relatively acute presentation. And there is a polyurea. Now, what's going on here? Why does the patient have a polyurea? Well, the patient is not producing any insulin. Therefore, blood sugar levels are going to rise. There's going to be a hyperglycemia. Now, if there's a hyperglycemia, that means that there'll be large amounts of glucose in the blood, and glucose is readily filtered from the glomerulus into Bowman's capsule in the renal tubules. So as the blood sugar levels rise, the amount of sugar in the renal tubules, in the nephrons, is also going to rise. And some of this will be reabsorbed. The renal tubules have the ability to reabsorb about 11 millimoles of glucose as that glucose passes through the renal tubule. Any more than that, and they won't be able to reabsorb it all. That means in the distal part of the convoluted tubule, there will still be a lot of glucose molecules. And glucose, of course, is a very osmotic molecule. Glucose will suck water to itself. Remember, osmosis is the movement of water across a semi-permeable membrane under the influence of osmotic pressure. So the glucose within the lumen of the nephron will generate an osmotic pressure. That will attract water unto itself. It will suck water into the lumen of the nephron. If you like, the water is trying to dilute the glucose. So what this means is, yes, there'll be a glucose urea, but you won't know that by looking at the urine. You'd have to test it or taste it to decide that. But the glucose is osmotic, so it's sucking lots of water with it. So as the kidney is excreting glucose, it's going to excrete lots and lots of osmotically attracted water with it. And this is called an osmotic diuresis. There is a diuresis, which is an abnormally large amount of urine being produced. And that diuresis occurs for osmotic reasons, because of all this glucose that can't be reabsorbed. So there's a polyurea, and that polyurea is a glucose urea. And as large amounts of water are being eliminated from the body, it could be huge amounts, I mean, many litres per day, then obviously that's going to reduce the amount of water left in the body, and the patient is going to become dehydrated. And of course, as the patient becomes dehydrated, that's going to make them thirsty. Simple as that. So they're going to be very thirsty and drink lots and lots of water. But even though the patient's drinking lots of water, very often the water drinking can't cope, and these patients can develop hypovolemia and eventually low blood pressure, because of that, because they're excreting so much water. But they will be very thirsty, and they'll drink and drink and drink to try and replace the water which is being lost by the osmotic diuresis. So, first two parts of the classic triad, polyurea and thirst. The third part is weight loss. Now, remember that the mitochondria like to use glucose to produce the energy. And of course, the mitochondria are inside the cell, and the glucose is outside the cell. And because there is no insulin in type 1 diabetes, the insulin receptors aren't triggered. There's nothing wrong with the insulin receptors. They work perfectly. It's just that there's no insulin to stimulate them. That means that the glucose transporter molecules are not able to transport the glucose into the cells. And this is the great irony in diabetes. In type 1 diabetes, there is huge amounts of glucose in the blood and tissue fluids, really, really high levels, but none in the cells. So there's masses of glucose, it's just all in the wrong places. It should be inside the cells where it's being used, but it can't get in there because the insulin is not there to open the glucose gates. So what this means is that the mitochondria are obliged to produce energy from other sources. And the other sources they use to produce energy are fats, and energy will also be produced from proteins. So the mitochondria are burning fats and proteins instead of the glucose they would like to burn. And of course, as they burn fats and proteins, that means that fat and protein are going to be lost from the body, and there's going to be a weight loss. So the weight loss, well, acute weight loss is partly dehydration, but the ongoing weight loss is that the body is burning its own proteins, it's burning its fat reserves to produce energy instead of glucose. So it's not really surprising there's going to be weight loss. And also in this circumstance where the body is burning fats rather than carbohydrates, ketones will be produced. Now we're going to talk about ketones in more detail later on, but let's notice for now that ketones are organic products which are made when fats are burnt in the absence of carbohydrates. So if there's a ketosis, again, that's a good indicator that there is an insulin lack, because it means that fats are being burnt in the absence of carbohydrates. And that can be detected in the urine or in the blood. So if there's a polyurea, especially if there's a glucoseurea, if the patient is thirsty or the patient is losing weight, such a simple test the patient's blood sugar levels and see what it is. And very often a diagnosis is unfortunately only too obvious from that. Now glucose tolerance tests can be performed. That will see how the body responds to a glucose challenge. In type 1 diabetes that may not even be necessary. And then for an absolute diagnosis, if you actually do a biopsy of the pancreas, you see these inflammatory changes and destruction of the beta cells. So again, any form of clinical person you want to be, if you don't know that the classic presentation of diabetes mellitus is polyurea, thirst and weight loss, then you're not going to be very safe. There's other presenting features: lack of energy because the sugar's not getting into the muscles. There can be blurred vision because glucose can absorb into the humours of the eye and alter the internal refractive indices of the eye. Itching is quite common. Salt and water depletion, as we said, can lead to tachycardia, to hypertension. Over time, progressive weight loss, muscle wasting. Now the glucoseurea, the presence of sugar in the urine, can also lead to cystitis, vulvitis, balanitis in men, inflammation of the glans penis, because there's so much sugar in the urine, and it's just making these infections that bit more likely, that bit easier to present because there's lots and lots of glucose around. And as well as that, the white blood cells don't move very well through sugary movement, so the body's defense systems are going to be impaired as well. Right, so what the heck do we do about it? Well, as we've said, it's an insulin-dependent diabetes mellitus. So these patients need admitted to a medical ward and they need to be stabilised. And stabilization isn't that straightforward really, because as well as